Okay, good morning. My talk today about the breast cancer with the general information, how to deal with the breast cancer if anyone has been diagnosed with the breast cancer, especially for female and also for male, as a cancer can affect both sides. I'm talking about the October month, which is an awareness month of breast cancer. How this started, how the change has been made with this awareness month. It is the pink ribbon. It's an international symbol of breast cancer awareness being started with Alexandra Penny, which is the author of the big magazine in New York City. It started in 1992 when she went to the New York City streets and distributed the pink ribbon, trying to encourage the market to have a discount and make awareness about the breast cancer because her grandmother suffered a lot of breast cancer before she died. So now the pink ribbon is, when you see it anywhere, is immediately think of a breast cancer awareness. What does it mean? Doesn't honoring the survivals. Remember those patients who died from this cancer, and also to support the progress we are making together to defeat the breast cancer. Is it working? Yes, it is work. You know, as the breast cancer campaign showed a lot of improvement in the breast cancer management. First of all is the early detection of breast cancer using the mammogram, funding the research for breast cancer treatment, and reduce the global breast cancer mortality by 2.5% per year, and knows who's at risk, you know, for breast cancer, be familiar with the signs and the symptoms, and support the breast cancer survival, since, you know, we have a large number of survival in the last 2 decades. It's been like really in the market, you know, in October months, when you go on the street, you see a lot of marketing, even, you know, the unhealthy and fast food restaurants, they market for breast cancer. And I remember this Big Mac from McDonald's, you know, showed a big hamburger with pink buns. It's really, look, it's like two slices, you know, of hamburgers, very high calorie sandwiches, but actually made some difference in the community. So every person who try to, you know, consume all these products, they have the pink color and the ribbon in their face, so they are aware of the breast cancer. And also some brands names, even, you know, like Prada, Estee Lauder, and all this Gucci market in October, they provide with a lot of signs and awareness with the discount to even, you know, to collect money for the breast cancer research centers. So our job is let's beat this breast cancer. You know, it's very common in women, and we should work on it because woman is very important, you know, person in our life, in the family, in the community, everywhere. So having a cancer, diagnosed cancer in a woman is a really a disaster. Information and news in the whole family. So in these days, you know, we should be able to beat this cancer and have women live a normal life during and after the treatment. What is a breast cancer? Is a breast cancer happen when the cells in the breast grows and divide in an uncontrolled way, creating a mass, a tissue called a tumor. And as you see, this is, in general about the invasive ductal carcinoma, show you how the normal duct, in the breast tissue, and when the cancer cells start to grow inside the duct, they call ductal carcinoma in situ. That means it's still inside the duct, it didn't break the wall of the duct. When it starts breaking the wall of the duct, immediately should be considered like invasive ductal carcinoma. Epidemiology, breast cancer is the most commonly diagnosed cancer among women. And also it's 15 to 30% of all new cancer among women. And the next one is the lung cancer. So lung cancer and colorectal cancer. So breast cancer is the most common cancer in women, as like a prostate cancer is most common cancer in men. But in both sex, they have lung cancer is still the most common cancer in both sides. There's also men, there's estimation in 2019, 2,670 new cases of breast cancer among men. Still accounting less than 1% of all new cancer in men. 1 in 8 women will be diagnosed with the breast cancer, and 1 in 3 of these become metastatic. That means already stage 4. African American women, they are 40% more likely to die from breast cancer. The reason for that, because of the social life, the community, and the way they understanding the breast cancer. In 2020, there is about 2.3 million women diagnosed with the breast cancer. It's a big number, and almost like a quarter of it, like they die from their cancer globally. The clinical presentation is very important for every woman to know about it, because it comes in different signs and in different features, and we should not ignore it. A breast lump is the most frequent, symptoms on all breast cancer, but it can come in different symptoms and signs, like feeling a thick area in the breast, like a dimple in the skin of the breast. The nipples start to be crusty. The area of the breast turn to be red or hot. Some discharge of the nipple, like it could be bloody, or it could be just like like a saline, like water. And also there's some ulcerative in the skin. It might come this way, or a pump, just in the skin. And some new growing vein in the breast was was found before, and this is a new vein seen in the breast. And every woman, she will be able to know any new sign in her breast, because she's the only one familiar with the shape of her breast. And also there's a sunken nipple. That means the nipple retracted to the back, and also a palpable mass or something growing in the breast, change in the color of the breast, like orange peel skin, and also a hard lump. So all these symptoms and signs, every woman should be aware of it. And men also, it's easy for him to have his physical exam should be done at least like every 3 months, because it's easy to find a lump in the breast of men. If the nipple start to be retracted, there's some discharge from the nipple, or a palpable lymph nodes in the axilla. Screening for breast cancer. Mammography is the most common screening test for breast cancer, and it helps a lot, to improve the treatment of a breast cancer as being detected in very early stage. And women should have her mammogram from age 40. And I recommend to have her baseline of mammogram, and that's up to her if she want to do it every 3 years or 2 years, but at least there's a baseline of her breast with the mammography. Any next mammogram should be compared with the old one to see any changes or anything new in her mammogram. At age 50 to 54 should be done annually, and at even above the age 55, I recommend it to be annually, at least to the age of 60, but sometimes they recommend it if everything is okay and normal, she can have every 2 years. If there's a breast cancer running in the family, like their mom, their sisters, that means the patient should start very early to have a screening mammogram above the age of 30. This is a mammography, how it's being done. It shows a lot of changes in the breast. Oncotype help the patients to make a decision to have systemic chemotherapy to improve her local control in the future. And it comes, to the low, intermediate, and high risk, and depends on the age as well. There is something called MammaPrint or Oncotype diagnosis. Both of them, they give a prediction about the recurrence rate in the future, up to the 20 years. And but I noticed, MammaPrint, I haven't heard about it, when I was in USA, but when I came here, I noticed a lot of hospitals, they do it, and unfortunately doesn't give the right prediction. Why? Because it's been done, a lot of studies about it. It gives you only two options, to be low risk and high risk. The Oncotype diagnosis, it gives you the low, intermediate, and high risk with the numbers. That means there's borderline, there's gray zone. With the MammaPrint, we cannot predict how risk is it based on the just estimate is low or versus high. And there's a study being done with the Prosigna. Prosigna test also similar to the Oncotype. They test 50 genes, and they predict, about the risk. So what they did, they got all these patients with low risk cases, and the MammaPrint, they found out with the Prosigna, they are 20% of them are high risk, which is a good number of patients. And 43% of intermediate risk with Oncotype. So those being by MammaPrint, they said is low risk. It was found 20% of them is high risk with the Prosigna, and with the Oncotype, 43% of them, they were high risk. So how do you trust this MammaPrint? It's really hard. So MammaPrint didn't show prediction of chemotherapy benefits in another study. And this is here the MammaPrint with the low risk but have a clinical high risk. They found out, having chemotherapy has benefits, 31% of risk reduction. So those patients, they came with a clinically high risk. It looks like, she has a big mass, and she has maybe some, features like high-grade features, but MammaPrint tells you this is low-risk patients for recurrence in the future. So having chemotherapy for those patients, there is some benefits. They got like 31% risk reduction. That means it's not a low risk. And also with the high risk MammaPrint, and with the have clinical low risk, like small lesions and low grade, and for some reason MammaPrint tells you it's high risk patients, so she underwent chemotherapy. They found out, having chemotherapy for those patients, they didn't get any benefits. So that means MammaPrint doesn't give you the right prediction. This is Oncotype diagnosis recurrence score from 0 to 12% is low. That means patient has no risk, in the future to have recurrence or metastatic disease. No needs for systemic chemotherapy. Intermediate risk 13 to 25%. That depends, on the physician. Is a gray zone, and based on the clinical features, if the patient the doctor feel like this patient at risk, for her cancer to come back in the future, especially when she's young, maybe she will be offered systemic chemotherapy. And the high risk above 27%, definitely she will get benefit of chemotherapy. This is the staging workup. We have the stage 0 up to the stage 4. Stage 0 ductal carcinoma in situ need to be treated with as if like it's a real breast cancer. We cannot ignore it because there is almost like 50% of those patients, they will develop invasive cancer in the future. So I need to talk about this ductal carcinoma in situ since, you know, it's with the screening mammogram, there's a lot of cases coming up with the microcalcifications in the breast, no palpable mass, it was found by the screening. Still, ductal carcinoma, as I said, is growing inside the duct, that means it's not invasive. It's called stage 0 breast cancer. Now let's say, you know, with the microcalcification, they did biopsy and it came back ductal, labular in situ, not ductal in situ. When it's labular in situ, there's no need to finish the treatment because in all labular in situ in the breast, that means she has a labular in situ on all sides of the breast. So there's no need for a lumpectomy, there's no need to do anything for it. Just wash it and maybe put her in a hormone treatment. But for ductal carcinoma in situ, the chance to develop invasive is very high and should be, deal with it seriously. As I mentioned, you know, it looks like a macrocalcifications in the mammogram. And usually we need to do stereotactic biopsy of those macrocalcifications and having lumpectomy, including all the area with the macrocalcifications. Sometimes it comes very large size, sometimes tiny area. So they measure those macrocalcification expand in the breast and should be all removed by surgery. So what they do, they do what they call it a wire localization surgical lumpectomy. They put the wire around this area and the surgeon remove it. And the next step after they remove it, they do x-ray, taking a picture of the specimen to be sure the wire with the area being around this area being removed completely. So basically the treatments will be breast conserving therapy or mastectomy. A lot of women, they don't like to lose their breasts, so it's good to have lumpectomy and having radiation after to preserve their breast. Some women, they tell you, no, I need to remove it all. Sentinel lymph node biopsy should not be offered for ductal carcinoma in situ unless if it's really a comedo and very large size. At this point, you know, they recommend to have sentinel lymph node biopsy. The chance for the ductal carcinoma in situ to be involved in the lymph nodes is almost like 0 to 5%. So it's very, very low. So that's why there's no need to do sentinel lymph node biopsy in ductal carcinoma in situ. And of course, you know, based on the receptors, the patient will get benefits of hormonal treatment after. So if we have multifocal lesions or multifocal macrocalcification in the breast, a lot of surgeons, they tell you, okay, this is multifocal, we have to remove the whole breast. This is not true. I mean, if those focals are close to each other and involving one quadrant of the breast, we can remove this quadrant and save the breast. But if you have like distant between those two focal areas, like really large distance, required a lot of tissue of the breast to be removed, at this point, you know, mastectomy will be recommended. We should achieve, you know, negative margins after the lumpectomy. For some reason, if they told you it's a closed margins, especially in ductal carcinoma in situ, closed margins, or they are not sure about the margins, or even 1 millimeter, now the standard to have at least 2 millimeter margins around the tissue, just to be sure, you know, it's safe to proceed with the radiation because they have to go for re-excision. Unless if the surgeon tells you, oh, I cannot remove any more breast tissue, at that point we have to pay attention to the adjuvant treatment to focus in this area and take care of it. Now, if the patient has a lot of microcalcifications and she had lumpectomy before we start radiotherapy, even the margin they told you is like more than 2 millimeter and everything looks fine, at that point I recommend, to have mammogram after the surgery to be sure there's nothing left in the breast with the microcalcification. Mastectomy, this is the other options, for ductal carcinoma to remove the whole breast. When they remove the whole breast, there's no need for adjuvant radiotherapy because, the whole breast be removed, nothing to be treated. It's good, is really curative. Over like 98% of the patient with ductal carcinoma in situ, and that was actually the treatment about like 25 years ago. That was the only treatments for ductal carcinoma in situ. The radiotherapy after lumpectomy, this is really important because a lot of patients, they ask you, oh, we are like stage 0. That means our cancer is not invasive and the surgeon removed all of it, nothing left in the breast. Why you need radiotherapy? Actually, it's very important to have radiotherapy if you have lumpectomy. The reason for that, because I think there's a study being done. This is NSABP B17. They took those patients to have lumpectomy, nothing to be followed by adjuvant radiotherapy, to have lumpectomy and radiotherapy, and they found out, radiotherapy is improved the local control by 50%. So this is really important to have because if you don't treat the whole breast after lumpectomy, the cancer might come back. And that's, another study being done when they compare 3 groups. Group went for mastectomy and a group went for lumpectomy, and the third group went for lumpectomy followed by radiation. And this is a major study about like 10,000 of women being involved in that study. And with the follow-up 5 to 10 years, they found out mastectomy group, they do the same as lumpectomy with the radiation. But the group with the lumpectomy alone, their cancer came back within, especially in the first 5 years. The radiotherapy is really important to be done after the surgery with ductal carcinoma in situ. As we said, is improve the local control. And what we treat the whole breast. We're trying to give the condition of the patient as if like she has mastectomy. So any potential microscopic cells left in the breast, the radiation will take care of it. So the whole breast should be in the field, part of the chest wall. And sometimes, we include the first echelon, of the lymph nodes. That will be included automatically with the treatment. And after treating the whole breast, we give a booster treatment to the tumor cavity. As you see here, in each planning, we have to contour the tumor cavity and have margins around it to give the booster treatment. And this is about like 1 week of treatment. What type of radiotherapy? We used to do like a conventional radiotherapy to the whole breast, which is about 6 weeks of treatment, 5 weeks to the whole breast, and 1 week for the boost to the tumor cavity. They found out, Canada, they do really well with the 4 weeks of treatment. They call it hypofractionation, which is, we call it actually Canadian way to treat the breast cancer. And now it's the standard treatment in these days. Even American people, they use the Canadian way, which is 3 weeks high dose of radiation to the whole breast and 1 week for to the tumor bed. And they have the same result, the same, control rate in the future. Okay, can we omit the radiotherapy after the surgery? Yeah, we can do it, especially, in certain situations. If the patient is very old and the cancer, of her ductal carcinoma in situ is low grade, a small area, the risk for her cancer to come back is very low. Those patients, if they can continue with the hormone treatment, no needs to have radiation and, put him on 4 weeks of radiotherapy. Now, what about the early invasive breast cancer? If the patient comes with a T1, now is invasive. That means the tumor is crossing the ducts of the breast glands. They can have the surgery, lumpectomy, or mastectomy, chemotherapy, neoadjuvant or adjuvant immunotherapy, especially with the HER2 positive, and radiotherapy and endocrine therapy. So all this treatment should be involved of the early invasive breast cancer. And how it goes like first depends on the pathology, depends on the breast cancer team, physicians, they decide which is good for the patient to start with. I will talk about the sentinel lymph node biopsy. It's really, now it's in the last, I think 15 years or maybe 20 years, they started to do sentinel lymph node biopsy instead of the dissection. Dissection, they used to go back, if any invasive cancer, they have to do the lumpectomy and have dissection of the axilla, which is removing at least like 10 to 20 lymph nodes and examine those lymph nodes to be sure there's no cancer in it. With the sentinel lymph node biopsy, the whole thing's been changed. They have a small cut in the axilla, and they remove only those lymph nodes, being dyed based on the injection around the tumor. So they save a woman a lot of side effects related to the surgery, including the lymphedema in the arm, and the pain and the recovery. So this is the way it's been done. The physician will inject the radioactive substance or blue dye around the tumor and wait. Usually they wait like a few hours, and then when they go for surgery, they follow those with the special tracer, and find out where those dyes went and have a cut and remove all these lymph nodes. Usually they remove between 1 to 5. Depends, where the dye goes. Is recommended for all T1 and T2 and has no clinical palpable lymph nodes or by the ultrasound. Why? Because when they start having clinical palpable lymph nodes, they have to go for dissection. That means the cancer is already there. So there's no need for sentinel lymph node biopsy. Can we give a neoadjuvant chemotherapy in early breast cancer? This is very common in these days. What the advantage of having a new adjuvant chemotherapy? First of all, is downstage the extent of the disease. If the patient present with the big mass in the breast and to having lumpectomy, that will affect the shape of her breast, it's good to have a neoadjuvant chemotherapy to shrink the size of the tumor. I'll also evaluate the effectiveness of the systemic therapy, and also if someone has a triple negative. Triple negative is very aggressive disease of the breast cancer, and having a neoadjuvant chemotherapy is reduce the chance to have metastatic disease and also reduce the size of the tumor and the lymph nodes. And most of them, there's a big chance to have complete response to the treatment. So I want to tell something about when we do biopsy for invasive cancer, especially the core biopsy, we should drop a marks where we did the biopsy, because if someone going for a neoadjuvant chemotherapy and has complete response to the treatment, the surgeon will not be able to know where was the tumor. So it's good to have drop some marks, before we start the treatment. Surgery, as I said, lumpectomy with sentinel lymph node biopsy, this is standard, and also mastectomy. This is type of surgery being done for breast cancer: lumpectomy, wide excision, quadrinnectomy, and mastectomy. What the indication if someone removed the breast in invasive breast cancer? Why we need to have radiation after removing the whole breast, which is different from ductal carcinoma in situ at stage 0. In invasive cancer, there's some indication to have radiation to the chest wall. First of all, when the tumor size is more than 5 centimeters, it's good to have chest wall treatment. When it's inflammatory, breast cancer, when it has multiple positive lymph nodes, a lot of patients, they tell us, okay, they remove the whole lymph nodes and we need to treat only the lymph nodes area. Why we have to treat the chest wall? They found out there's a lot of study of treating the lymph nodes and not to treat the chest wall. The chance for the cancer to come back in chest wall is very high. So any patients having positive lymph nodes and nothing, in the breast, just a small lesions, we should include the chest wall and the regional lymph nodes to improve her local control. And of course, if she has positive surgical margins and the surgeon unable to remove more in the chest wall, she should have radiotherapy to the chest wall. This is the difference between treating the breast and the chest wall. The chest wall is similar technique in both areas, but we have to focusing in to be sure the skin and the chest wall has a good dose of radiation to prevent recurrence, and also we have to protect, the lung and the heart. What about the endocrine therapy, especially with the hormone receptors positive? They got a lot of benefits, of hormonal treatments for breast cancer. There's different type of hormonal therapy. The blocking the ovarian function, especially in young females, they called ovarian ablation. There's some medications to block the ovaries. Sometimes, they have to do for surgery, oophorectomy. The other way is blocking estrogen production with the aromatase inhibitors, like blocking the enzyme called aromatase, like Arimidex or Femera. Those well-known medication, they use it especially for postmenopausal patients. And blocking estrogen effects such as tamoxifen. The blocking estrogen effects with the tamoxifen is well known, against the breast cancer, because it's bind to the estrogen receptors and especially in the breast. So it's blocking the estrogen effect in the breast, but at the same time, it's actually works as an estrogen because it's bind with the estrogen receptors, especially in the uterus and the bones. So I would say some woman with the osteoporosis is good to have tamoxifen. It helps her bone. And the other things, if someone has issues with her uterus, she's at risk, to have cancer, is not good for her. Plus, if someone is smoking, also is not good for her. Tamoxifen versus aromatase inhibitors depends on the age. They recommend it for young females. Premenopausal for aromatase inhibitors is good for the postmenopausal, and they found this is more effective than tamoxifen. And this is, the table. They show you how to use the hormone treatment. What about the inflammatory breast cancer? Inflammatory breast cancer is a special cancer on the breast, which is completely different from what we used to see in the breast, like a palpable mass, palpable lymph nodes, nipple discharge. It comes like changing in the color of the breast, very painful. The breast looks like bigger, very aggressive, and should be treated immediately. The symptoms, as I said, is swelling, redness, pitting or thickening in the skin. The skin, it looks like really thick. One of the breasts looks like larger than the other one. The breast feels like warmer. That's why most of the patients, they think they have mastitis, like infection in the breast, and they've been treated at least like 3 to 4 weeks with the antibiotics with no improvement. So that means she should think about inflammatory breast cancer. This is the way it looks, like darker and thick and really tender. And the nipple sometimes distracted to the back. And you can see this looks like an orange, skin. The treatment was all inflammatory breast cancer. They should start with the neoadjuvant systemic chemotherapy. This is really important because they have a good response to the treatment, and also protecting from any distant metastasis disease because it's very common to have distant metastasis disease with the inflammatory breast cancer. Also shrink the size of the tumor, so the patient will notice improvement after 2 cycles of chemotherapy. After she finished the systemic chemotherapy, she will go definitely for mastectomy. There is no breast conserving treatment for inflammatory breast cancer. The whole breast should be removed. And following the surgery, definitely she needs radiotherapy and then hormone treatment. Okay, what about the genetic testing? I'm just giving some general information that every woman should know, and what she asked for when she goes, when she found out or any one of her family have breast cancer. Genetic testing is really important when the cancer diagnosed in early stage in any woman, and especially with those with the triple negative, receptors. Those they have to have the genetic testing because most of the holding the genes BRCA1 or 2, they come with the triple negative cancer. And the Ashkenazi Jewish heritage, they are at risk for BRCA mutation, and most of the European countries also, they hold these genes. If someone has a family also member like having ovarian cancer, even different kind of cancer like pancreatic cancer, and those they are able to ask for genetic testing to rule out they don't hold the BRCA. The BRCA1 and BRCA2 mutation has 45 to 65% chance for having cancer in their life. And let's say, one of the women, it came back positive for BRCA, and should be done before we start the treatment, because if she decided to do for bilateral prophylactic mastectomy, that depends, we don't have to do only treatment to the affected breast. She can remove both of them and ask, for reconstruction or another, treatment. Also, some women, they remove their ovaries to protect, having ovarian cancer, because the one who holding these genes also at risk for ovarian cancer. If someone wants not to do anything, they have to have very close watch out for the mammogram, even MRI, from the age 30. Since we have a lot of advanced technology, and there's the survival of a breast cancer is above 90% now. That's really a good number, but we should pay attention to the one who survived. You see patient after 15 years, 20 years, but what they have in their life, because after the treatment of their breast cancer, a lot of it changes, in their life, in their community, in the social life. Even, some women, their family being destroyed because of their cancer, because someone has like a mastectomy for some reason, got divorced, So all this stress they live after should be considered with the group support, cancer, and follow up, with the physician all the time. The cancer support group, why is very important for breast cancer? Because when the patient finish all her treatment and her chance to be survived is very high, they have this fear, the cancer will come back one day. Even, after 15 years, they have this fear. There's like something, it's like a ghost, following them. The cancer might come back anytime. It's in my brain or in my bones or anywhere. So those, they have to have, give him some information about the cancer, how to teach them how to live their life without thinking about this fear. That will relieve them a lot of stress, in their life. And they should have to be involved in the community, have working as if like they are normal people, and also help because of the change of their shape. They have to, those groups, they have to help those survival to be back, to be beautiful, to be the way before, and have a normal life, because they live for a long time. They live like 40 years, 45 years after. Okay, some tips, to reduce the breast cancer risk. Everyone knows about these tips. No, keep healthy weight. No Big Mac. That's we saw in the beginning. Get enough sleep, exercise, don't smoke. Breastfeed your baby. Breastfeeding is really help the patient to reduce the risk of breast cancer and less drinking alcohol. And that's why, we are survivals of all age, from young to the elderly people. Any question?